Thank you very much. First off, I'd like to start to thank Natalie. She was a major part of this study, so I just want to mention that. And then I have something to disclose because I received an unrestricted research grant from SLE London. However, they were not involved in this study in any way, so that's good to know. So as you have probably heard this morning, the therapeutic range for supplemental oxygen is very important. It's important for the outcome of the patients, and we've also seen this in the near-prompt trials, for example, where a higher target range was associated with an increased chance of retinopathy of prematurity, whereas the lower target range was associated with an increased chance of necrotizing enterocolitis or mortality. And there are actually more studies out there which associate hyperoxia with retinopathy, BPD, and other outcomes, and also hypoxia with necrotizing enterocolitis and ROP as well. We don't exactly know what the best target range is, but we do know that even if we choose one, the infants will spend, the extremely premature infants will spend quite a long time outside of this target range. So some have described this to be only 30% inside the target range. And luckily, actually what I want to say is when we do this manually, this is especially the case. Luckily, there are machines which will do this for you. They will measure the oxygen saturation in the blood and then adjust the inspiratory FiO2 accordingly. And trials have shown that this has a beneficial effect on the time spent within target range, and also the occurrence and the duration of deep hypoxia and hyperoxia is also diminished. This is of course very promising, but most of the trials actually only measured for 24 hours of automated oxygen control. There was one study which measured for longer by my colleague Henriette van Zanten, and none of these actually assessed what the clinical effect was, so on clinical outcome. We participated in the LEMC, we participated in one of the trials, and we were actually convinced it would be beneficial for our preterm infants. And also our nurses really loved it, and it's easy to understand why, because it, it helps them keeping the saturation within target range, and it gives them more time for other important tasks, other nursing tasks. They are busy enough, so this is a very helpful tool. We decided to introduce it on the 18th of August in 2015, and we thought, well, if we implement such a technology, we should really evaluate after a few years what the effect was. So we took all babies born since then under 30 weeks of gestation until December the 31st of last year, and we matched this with an equally sized cohort, which we'll call the pre-implementation cohort, the 3 years before. We assessed in the patient files what if they developed any retinopathy of prematurity. We looked at if they developed bronchopulmonary dysplasia, and we also looked at what sort of respiratory techniques were used, what sort of therapies they received. We looked if they developed necrotizing enterocolitis, IVH or PVL, intraventricular hemorrhage or periventricular leukomalacia, and we also looked if they stayed on our NICUs longer, and if they received any invasive ventilation, how long they received this. So on to the baseline characteristics. I hope you can read it all in the back. What you can see that both cohorts consisted of 306 patients, and all the baseline characteristics are actually quite similar. So slightly more males, around 28 weeks of gestation. The birth weight was around 1,030 grams, and most of them received antenatal corticosteroids. About half of them was delivered by cesarean section. You would notice that we have more twin and triplet pregnancies in our center than maybe your own. And this is because we are a referral center for fetal therapy for twins. All right, on to the respiratory outcomes. So we saw that they received a similar rate of HFO, nitric oxide, and dexamethasone, and it does seem like they received slightly less surfactant in the post-implementation cohort, but this was actually not statistically significant. What was the method we delivered the surfactant, which actually makes a lot of sense because we switched over to the MIST procedure, or LISA as some of you may know it, about halfway through the pre-implementation cohort. If we look at bronchopulmonary dysplasia, you can see no statistically significant differences there. But if we look at how many invasive ventilation days they received, then this was statistically significantly lower in the post-implementation cohort. We thought this might be related to the way we deliver the surfactant, because of course with MIST you don't have to intubate them anymore. So we adjusted for this, as well as for sex, gestational age, and the birth weight, and this was still a significant difference. On average, they received 1.4 fewer ventilation days. In this graph, it's shown a little bit better, so I'll quickly walk you through it. The orange, or the top one, is the pre-implementation cohort, and the bottom one is, of course, the post-implementation. And the wider the graph is, the more babies receive that many invasive ventilation days. So what we want is that on the left it's very wide, and luckily in both cohorts this is the case. So most infants actually only receive 0 days. But if you then look at the median, then you can see that in the post-implementation cohort, which is the dashed line in the blue graph, that's a lot lower than in the orange graph. The dotted line is the 75th percentile. So on to the other outcomes. Mortality, not significantly different between the two cohorts, and no difference in necrotizing enterocolitis either. Actually, this was exactly the same. And then retinopathy of prematurity, which we might have expected a difference. We didn't see a difference either. We looked at the ETROP criteria, which the eye doctors actually use to determine if an infant should have laser therapy. And we also looked if they actually received laser therapy, and there were no differences there. Intraventricular hemorrhage and PVL, no differences there. And as you might expect, days on the NICU was actually also exactly the same. To conclude, I think we can say automated oxygen control did not lead to a decrease or increase in short-term morbidity or mortality. And although this might seem like a pity, I think it's also important it didn't make our babies more ill. So, and there are benefits to it. So I think it's an important result. And in the post-implementation cohort, they did receive fewer ventilation days. And that's actually also very important because those are associated, if ventilation days are associated with neurodevelopmental outcome. So all in all, I think it's very exciting. Thank you for your attention.